Nirti.
Yeah, we can go live.
A very good evening, everyone. Welcome to iFocus Online, Lecture 253, number 40 in our series from Squint and Paediatric Ophthalmology. And today is a masterclass by none other than Dr. T.S. Surendran sir from Shankar Nethralaya, Chennai. And he's here to give us an overview of Strabismus, my lessons of a lifetime. I invite Pradeep Sharma sir to introduce him, although he doesn't require any introduction, and to welcome him for this evening.
Thank you, Shefali. I think it's a great pleasure to welcome and introduce Professor T.S. Surendran, a great time person who has been, we have been together for the last 43, 44 years. And it's a pleasure that he and we were sharing the co-fellowship with Dr. Prem Prakash. Currently, he is the Vice Chairman and Director of Paediatric Ophthalmology, Shankar Nethralaya, Chennai. He's been the Director of Orbis, Trustee and Board Member of Shankar Nethralaya, Chennai, and Shankar Dev Nethralaya, Guwahati, Assam. He has been the Chairman of Institutional Committee for Stem Cell Research, Government Stanley Hospital, Chennai, and Board Member of the Chennai Breast Cancer Research Foundation. He has been trained under Marshall Parks, Alan Scott, and also my mentor, Dr. Prem Prakash. He's been a passionate teacher, physician, and researcher, delivered numerous lectures, and has publications in national and international journals. We are all eager to listen from Dr. Surendran. He has received several awards. The Lieutenant Colonel Rangachari Gold Medal from All India Ophthalmological Society in 1989, Dr. Joseph Gyanadesikan Award from TNOA, Lifetime Achievement Award from SPOSI, Vista India Communications, TNOA 2018, and he has been the Scientific Secretary and Founder Member of APOS and the founding member of SPOSI, or the SSI, the Strabismus Society of India. He's been chosen as the best doctor of South 2022 in ophthalmology pediatrics by Outlook magazine. So it's going to be a great pleasure listening to this masterclass from really a great master, Dr. Thandalam Surendran. Over to you, sir.
Thank you. First of all, thank the Dr. Santosh Hanover for choosing my name, because I've been a little out of academics for 5 years. I have not attended our SPOSI conference also. So this actually has stimulated me to get into little academics. I am now reaching 70, so I thought I'll slow down a bit. Next slide, you have a slide to start. Bansal.
Tulika, you're muted. Do you have the slides? Are you sharing it?
Yes, sir. Shefali, could you please go ahead and start the slideshare? So we have it with us downloaded, so it has shared it with us.
Shefali, you're muted.
Yeah.
Put it on full screen. Okay.
Okay, Santosh asked me to talk on overview, but the note which he sent said master's view. So I just clubbed both the overview and also our experience for the postgraduates, what all they should do. So I jotted down some points. Can I have the next slide, please? What is strabismus? Strabismus, I think, looking obliquely, they say that Italian term strabo means looking obliquely like that. But whatever it is, the eyes are not in alignment, misalignment. Next, one eye directed towards Hyderabad, one eye directed towards Chennai. That is what is strabismus. So first of all, when the child reports to you, I think with strabismus, I think they can have less vision, especially if one eye is squinting more often than the other eye. That is called a strabismic amblyopia. And next. Next bullet point. So the strabismus also can be caused by congenital cataract, especially the one-eye cataracts. I think they have very poor prognosis because they develop eccentric fixation and uncorrected refractive errors, as you know, which is very common, and central corneal opacities and retinal pathology. Today, I had a patient with Coats disease, it's a police inspector's kid, and the child had Coats disease, and that is why it was diverging. But I was surprised, a 2-year child with a divergent squint, because with the tonic convergence, they usually squint inwards. Even most of the retinoblastomas, they all squint inwards. And even ROP children, grade 4, grade 5, they all squint inwards. And of course, they also have what they call as pseudostrabismus most of the time because of the pulling of the macula. So any optic nerve pathology, mentally retarded children, they all have strabismus. Next. So amblyopia is a very big chapter. Before that, I think I will just come to the basic things. First, when you do the history taking actually, you are supposed to take the first look at the previous records, because most of the time the people who come to us has already consulted Santosh Hanover and Pradeep Sharma, and then come to Shankar Nethralaya. So unless you pick up those files, you will not know how many people they have seen. One patient had seen 6 consultants all over the country, and they will be hiding it, they won't tell. Then once you tell diagnosis and all, then they will compare and they will bring it out. And few people, they may not bring it out. So it is better that I think before we start a good history, first they will say that squinting of the eye, right eye or left eye, intermittent or doubtful squint, like that it will come. A lot of pediatricians also send cases with pseudostrabismus. They diagnose more pseudostrabismus than true strabismus. True strabismus people, the pediatrician whom we send, they all come after 5 years. The pediatricians whom I get, they are all very smart, even slightest doubt they send. And they will have half of them pseudo squints, half of them true squints. This is in reality. Whereas other 90% of the pediatricians, Chennai, I think they are not aware that squint should be treated early. They are not aware of both the amblyopia part and binocular vision, stereopsis, etc. So strabismus can itself decrease vision, amblyopia, which is, if it is constant misalignment, it can be a dense amblyopia and causing central suppression and causing what they call as lazy eye. And many times, I think, unless it's a latent squint, they do lose binocular vision. If it's a latent squint, they will have binocular vision. So when you are checking initially itself, I think as you check the history, you will also have to check the visual acuity. And the visual acuity, we throw a lot of cards, pictures for pre-verbal children. Next slide. Next slide. So sometimes I think strabismus also can be a sign of life-threatening condition like retinoblastoma. Invariably, retinoblastomas, they have esotropia. But today's case, Coates case, I was surprised, a large exodeviation. Then we have sixth nerve palsy, which is also having ESO. Strabismus can be and increased intracranial tension, meningitis, and all this can cause either unilateral abducent palsy or bilateral abducent palsy. Next. Vision testing. Vision testing is an art, because if you are having a 2-year child or 3-year child, I think they just give you enough trouble and takes long time. So first the optometrist checks up, and I have a lot of this Apple pictures. Even Appasamy unit has that pictures, and I try to record it again. And so I think twice at least, I think we should record the vision. And mother or father has to close the left eye tightly and then close the right eye, because they tend to peek and cheat. And so my lecture actually today is more of practical things, what you expect in the clinic, how all they cheat. First of all, choosing pediatric ophthalmology is a very tough thing, because examining the child is a very big challenge. I have developed backache now with more than 1 lakh patients being seen. And refraction, actually, the retinoscopy I myself do, because I don't believe the optometrist, because some may be junior, some may be senior. It is better that we recheck it. To that extent, that this hand has done 1.5 lakhs retinoscopes and developed tennis elbow 5 times. Again, physiotherapy, again, I am back in action. So recently, last episode was 3 months back, but I managed. So most of the things now I have started using the left hand. Indirect ophthalmoscope, I am using only left hand now. And slowly trying retinoscopy also with the left hand. But right hand, I am very confident that with the thickness of the beam, I can tell +4 or -4 like that. Invariably, it will be correct, because that 1.5 lakh retinoscopes. So this thing to the students will be that you take over from the optometrist and do the retinoscopy. The first thing what my guru did after Prem Prakash, Dr. Badranath gave me a book. I think this was for the nursing students. He gave me a book, and this had the first thing is to learn refraction. And so he put me for refraction. That's how I developed a soft corner for refraction, and I am stuck to that, and I'm still going on. So this helps me when a chief minister comes to my clinic also, I can do refraction myself. I don't believe assistants to do that. Then you have assessment of the strabismus and the various ways, the prism bars. And I think the more experienced you are, you can check with what we can say, the torchlight test, no? So the corneal reflex, if it falls on the pupil, it is 15 degrees like that. So I think that gives fairly good this thing. If it falls on the limbus, it is 90 prisms. So today, 2 cases of infantile esotropia, they had more than 70 prisms. So I had to do bimedial recessions. So it is very important that angle is assessed. And if the child is cooperative for the prism bar, you can use the prism bar. And after that, I think after checking visual acuity and other things, important thing is to check the previous photographs, because sometimes there can be an anomalous head turns, face turns, or chin up or down. All this can happen. So you'll have to check with the, especially group photographs, the marriage photographs, or if the child has taken as group class photographs, you can pick up very easily whether the child is squinting, which child is squinting, whether the photo has been reversed, or whether there is a face turn or this thing. So very easy. Face turn means you have a horizontal muscle problem, lateral rectus palsy, or it can be concomitant. Then you have chin elevation or up, then superior rectus and inferior rectus. Then the cyclo tilts. Tilts are usually due to cyclovertical strabismus like superior oblique palsy or inferior oblique palsy. So I think that also you should check. You must check with the parents, the reports, previous reports, then previous photographs. And on the slit lamp, especially little adults, you see whether there is any scar on the conjunctiva. Because one person from Santosh Hanover place, not from Hyderabad, Andhra Pradesh, he told no operation was done because that I had just PL. And he doesn't want the good eye to be operated. So very easy for him is to say that no operation was done. You do this side, which is amblyopic eye. So I saw on the slit lamp, I saw the scar on the medial rectus, lateral rectus. So if you use little magnification, you can make out the scar. And there are many dupers like that. So super dupers, they will try to confuse you. Then I think you make a note and you check with the previous photographs, ask him to take the previous photograph. Suppose if that photograph shows a divergent squint, and if he has a convergent squint, it means after the first surgery, overcorrection has happened. So you know how to plan. And even they will also tell orally that the squint was going outwards or inwards. And this is very, very important, because you should not land up after opening the eye. Then you will be surprised that muscle would have been recessed 8 millimeters, 7 millimeters, which actually is calculated from the limbus. You minus whatever it is. Medial rectus means you minus 5.5. Lateral rectus, you minus 6.5. So that will give you an idea how much recession has been done. Then you can plan whatever you wanted to do. And on the same eye, if you are stuck with the same eye. And while checking the fundus, this thing, I think children, we use what they call as little amucasthesia, I call them, because you hold the child in such a way that the hands are folded up and the legs are caught by the parents. The hands are held by my assistant. So the child cannot wriggle out. Then I use little force to open the lids and check the fundus. And suppose you have seen a congenital esotropia, and if you find an extortion of the macula or intorsion of the macula, then you know that you are also dealing with the AV patterns along with the primary gaze. It may be just 50 prisms. Then if there is an extortion, then down you will see 70 prisms. So it will be a V phenomena. So AV phenomena can be easily found out if the child doesn't cooperate. A 2-year child doesn't cooperate, you can find out with checking the optic nerve and macula. I don't go beyond equator area. I leave it to my retina specialist. 18 fellows are there waiting for checking whether ROP is there or any such thing. So, but I check up to equator. If it is all right, I leave them alone. And today I had a case which had a choroid, this thing that collarbone, what is it? Coats disease. So immediately they rang up and told it's Coats disease. They are going to plan for cryotherapy and laser, trying to save the eye. So if it is within your limits, I think better to send them off. Next. Preschool. So Manus reflex is just you throw your hand like that, and then if the child blinks, then I think the child is seeing. Preferential looking test, actually I had the opportunity of working in Children's Hospital, Boston. And there actually, they were the pioneers with the MIT. They found out this preferential looking test way back in '83. First fellowship after Prem Prakash, I had been to Richard Robb of Children's Hospital. Then I went to Marshall Parks. So preferential looking test, the pioneers are that Children's Hospital, Boston. That's a Longwood Avenue. Beautiful hospital. So there actually They just show with the contrast pictures on either side, and only thing is sometimes it will be erratic. The child may turn to one side which has these stripes. Sometimes it may not. So they will say, oh, today it is 6/9. And next visit they will say 6/60. The parents get very disappointed. But I told them, I think I have counseled the parents that this is just a very, very subjective test. And then your OKN is the drum. OKN is for that they just rotate it, and then you will find the gaze movement, saccades and all. And fixation pattern is important. That many people miss it. If you see any report, most of the time they don't tell the fixation pattern at all. Central fixation, the foveal fixation, that has to be written, because if it is eccentric fixation, then we will have to deal separately. And fixation pattern is very, very important, my dear young students. I think you should check with that visuscope and close the other eye. First, you always show it to a good eye and ask them to see. Once they see that plus mark, I think you can go to the next eye. Then they will be able to understand, and you will find whether it is eccentric, paradoxical, paracentric, etc. And pre-verbal children, fixation patterns and preferential looking, I always told you. Last for a couple of years, I think before, I used to use that Allen cards. They were very useful. Allen cards will have a cake, Christmas tree like that. And so these cards, if it is shown at 4 meters, they have a calculation. 4 meters is equivalent to 6 meters. That minutes of arc worked out in such a way that the whichever distance they see, they calculate. If the child is able to see at 2 meters, they know that it is 624, like that. So this Allen cards was very useful. Then our optometry team prepared idli vada like that with the same minutes of arc, so that our children can, because our children, they have not seen Christmas tree and all. So they duplicated that time, I think, when he came back from Boston. And visual acuity and refraction, as I told you, better you redo. Don't believe these auto refractors for children, because their Paediatric effect and cycloplegic, this thing will vary. And so don't do with auto refractor and prescribe the glasses. That's totally wrong. You'll have to just dilate with tropicamide and cyclopentolate, unless you are facing an accommodative esotropia, where you'll have to use atropine for 3 times a day for 3 days, and then check the retinoscope. And we prescribe, suppose you get 8, I start from 5, and see that I leave it them with either ortho or esophoria, but you must keep checking them every 4 months, because the plus number will decrease, and also the squint will start showing exo. It will move out. Then your duty is to bring it down. So this is another trick the postgraduates should know. Then you should check also the optic nerve, as I told you. And if there is any problem, send it to neuro-ophthalmology. So institutions have all branches under one roof. Very easy. And before surgery, next, this invariably our center, all the children go through the stereopsis test. And if they are not cooperative, they'll write they're not cooperative. If they are cooperative, they'll write 1 in 600 seconds, 1 in 400 seconds, 1 in 20 seconds, like that. And plus, we have also instructed to check the color vision. We found 1 out of 100 children have color vision problem. So, better to check the stereopsis, because this will give us an idea after intermittent divergent squints, the stereopsis may improve from 200 to 100 after performing the surgery. And I'm very fussy about, after discussing about the surgery, always, I think, tell the parents, after also examining with the prisms or Hirschberg test, how much is the deviation. The deviation has to be checked for distance, and it should be infinity. Your room may have only 6 meters, but you should check infinity. And infinity, what I do is I just rotate my chair and then open the main door and ask them to look at the patients who are sitting there. They will also be jumping to see what is happening. So once you see there, I think many times I have found out that what I checked in the 6 meters room, if it is 50 prisms, it has been 70 or 80 prisms when I open the door and see for infinity. So that is true divergence excess. That's why after surgery, you will find many times residual exo of more than 20 prisms because you have missed that 20 degrees, 20 prisms. And my criteria for performing surgery is more than 15 prisms, 15 to 20 prisms if it is there, especially if it is a phoric squint. They're able to control. Then I perform the surgery, and if it is also visible with the photographs. The photographs are very important. You yourself can take also. And before taking them for surgery, you will have to explain whether the child, whether the results of the child, how much it will take, and how much will be the success rate, and how many muscles are done. If V patterns are there, invariably we do 4. Today I had 2 cases which had 4 muscles. So 2 infantile esotropia, I did only bimedial recession. So totally 12 muscles I cut today. So invariably, I think you explain to them very clearly, and then they will say 100% guarantee. Especially, we get a lot of patients from Dubai and Oman and all, even that sheikh's children. So they ask for 100% correction. 100% means I tell them that I have a picture, common picture, like one child bowing to God. So I'll tell that, so Allah only has to give that 100% success rate. And also tell them that if it is not all right, I may plan for a second surgery. Then second surgery, if it is not all right, I may plan for a third surgery. Like that squint surgery sometimes. I think I landed up with one Bombay girl doing 5 times. And I'm not very aggressive like Marshall Parks. Marshall Parks, even 5 degrees of squint, he will go and recess another 2 millimeters. But cosmetically, it will be acceptable, but still you won't accept. I'm not that aggressive, but the trend is to cosmetically acceptable and try to manage with prisms and glasses. Next. So this and all has been covered, Santosh covered test, photo screener, PVAT, corneal reflex, prisms, synapta 4. I saw that number of lectures, all ESO deviation, exo deviation have all been covered in this 1 year or 2 years time. So I will skip this slide, and I am still using the synapta 4. I used to find it in RP Center where I got trained first. And synapta 4 still gives the angle in different things, and especially for patients with diplopia and incomitant squints. Plus, it gives a good anti-suppression exercises. So I club both anti-suppression exercises. On the same sitting, we have vision therapy. Vision therapy and synapta 4 are placed in the same room. So this works. Just 1 week or 10 days. If you do that, I think Remarkably, you will see from 624 to 69 many times if the fixation is in the central fixation and if the child cooperates. That is very important. Next. Hyperphoria, tropia. Cover uncover test, I think, right from the way how it is being done. Prem Prakash used to use the occluder. So he will have a 45 degrees angle to see what is happening under the cover. He will identify that fellow, how much it is deviating. And then he will switch over to the other eye. And it was a knack. You can know how the fellow does cover test, whether he has got any exposure with squint or not. Very easily you can find out. And some people do like this and all. It's all not correct. That's just with a finger. They will do like that and they may not use any instruments at all. All these are not correct. Phoria is a latent squint. Tropia is a manifest squint. And with the alternate cover, maximum total deviation is measured with the prisms. And then which eye prefers, you'll have to see. Dominant eye, which is the dominant eye and which is the less dominant eye. And for choosing surgery and all, that will be useful. And also treat the amblyopia. Next. This one video, I have not downloaded the videos because too much of the thing I didn't want to send. So cover test, as I told you, I have already covered this. Next thing we will go on to surgery. This one is the Hirschberg test, which is very famous. And this one is the prism bar cover test. So with the Hirschberg test itself, you will come to know what is the angle. And so I will just suppose this child you choose surgery. So what you will have to do is to, after checking the prisms, you plan for the surgery. You plan for the surgery whether you will be doing both eyes or one eye or this thing. If it is having a dominant eye, and then you choose the less dominant eye. And if it is 3D alternating, so depending on the palpebral aperture, I do. Suppose the left palpebral aperture is little smaller, right palpebral aperture, if it is bigger. See, these tricks the postgraduate should make a note. If left eye is little smaller and right eye is little bigger, but at the same time having 40 prisms of esotropia, you recess more in the eye which is smaller and recess less. Suppose it is 40 prisms, you should not divide and say bimedial recession of 4.5 millimeters like that. You balance 8 millimeters, you balance 5 in one eye and 3 in the other eye. So that way, because of the more recession, the eye will open if it is a smaller eye. If it is a bigger eye, then you do less. So palpebral aperture, we are entering Santosh Hanover's area. It's very, very important. Calculating the squints. And this also, I don't think it's mentioned in the books. So before surgery, again, check the name, the eye which has to be operated, and also check the name, check the eye, and check the muscle. Check the eye, check the name, check the muscle. And normally I go at 7 o'clock itself to the pre-op rounds, because before we were admitting previous day, but after 85, we have been doing ambulatory. So from 85 itself, we have been admitting the children. There is a 42-bed ward only for children. So we admit there, and the list those days used to be 17 to 20 in the summer, and a single surgeon. There was no other surgeon that time. And we will have to have a good anesthetic team, and also, I think whatever I think you have chosen to do surgery, you write it in a preoperative sheet. That's what Dr. Badranath used to do for retinal surgery. He will make a drawing, and then those days it was implants. You will put implant at this area like that. And where the fluid is accumulated, inferior detachment, you will put the whole area implant. You will make a mark and then paste it on the microscope. So that's what I do. I've been doing from day one. And there it will be written. Today also that case is OU medial rectus recession, OU inferior oblique myectomy. So it will be written very clearly there. So as I think you are operating, you keep seeing that the diagram and then operate so that you don't make a mess out of that and miss a muscle. And it should be your own handwritten writing. You should never leave it to fellows to write there. If they write instead of medial rectus recession to resection, that's all, you will go to jail. So, especially with all media stuff and all, we'll have to be very careful. So this pasting of the drawing is important. Apart from that, I call it as a Doordarshan. When the child, I always operate in 2 theaters. When I was doing 20 cases, also 2 theaters. Now I am doing not more than 6. Now also 2 theaters. So when you take the first case, I think you accompany the child and then make sure that the mother is comfortable. And then you again do the cover test on the table again, though before surgery, because the child would have been changed. We don't know. All today, actually, all were looking like Maida. That one came from Calcutta, one came from Chhattisgarh and all. All were looking Maida color, and all the children and 2 one-year children, they were resembling like twins. So that is the problem. If you mix up and then take the wrong child, because one child had 4 muscles, the other child had only 2 muscles. So you must do, I call it as Doordarshan. That is, they will lift the child and we have put in the operation theater one glass piece to see. So before anesthetizing in the other operation theater, they will show the child through that glass piece when I am operating the first case. And I will make sure that it is esotropia or exotropia and familiarity of the child. Some name I think you will remember. Vaguely you will remember. At least you won't make a mistake. Next one is exotropia. You won't be operating on an esotropia. Then only they give anesthesia. And by the time I think you finish the anesthesia, the next case will be ready. So making a drawing and then pasting it on the wall of the microscope, I think that is very important. The second thing is checking the child again before anesthesia, because our center, we have just this block only 5 theaters. 5 theaters. Today there were 24 general anesthesias, just 5 theaters. And Suguneshwari, she's a retina specialist, and she had some 7 cases of retinoblastoma review. So it's quite tough. Then another surgeon, Rajiv Raman, brings in a lot of retinopathy of prematurity cases. So it is continuously children are walking in and out. So it's very difficult that you should not mix up. And fortunately, it has not happened. In my more than 20,000 cases, I have not operated a wrong muscle. I have not operated the wrong eye. I have not operated a wrong child. This is because of my obsession of checking, rechecking, rechecking. Okay? So that has to be another point I thought as a master, because you told master. Then I use 6O Vicryl. And usually 1 Vicryl will do for 4 muscles. If it is the bilateral lateral rectus recession with the inferior obliques, just 1 6O Vicryl will do. And interestingly, I found last week I operated this Hyundai MD's daughter. She's a Korean. So Korean people, if you do Chinese or Korean people, if you do with 60, it will become like a tomato because a lot of reaction will be there. So I had to use, for the conjunctiva, I used 7-0. And for the muzzle, I used 6-0. Because this experience, I had it in Hong Kong when I was a visiting professor for 6 months. There we operated a lot of cases, and this I learned. First case I did with 6-0, and it was a lot of watering was there, and it was red and like a tomato. What else? The magic of the surgery on the table is that only 3 things are required. You'll have to assess how much to do, which muscle to do. Then your scleral bite is tricky, and hooking the muscle also is tricky. Today, 1-year child, I asked my fellow to hook. She had hooked both medial rectus and superior rectus. The tug was there. So because it is so close by. So as a surgeon, I checked up and then released that superior rectus. And many times when you are putting the hook for the lateral rectus from the upper side, you will invariably, if you are making a big sweep like Virat Kohli, then you will end up with inferior oblique also being hooked. This has happened at least, I would say, more than 50 times in my hands itself. Luckily, I have not cut, I have recognized. Then you release it, put the hook from the other side, release the inferior oblique, and then do it. And whenever you hook the inferior oblique, again, you'll have to make sure if it is children, whether you are really in the inferior oblique or you are hooking lateral rectus or inferior rectus. It has happened. And luckily, I have not cut it because I always check, however experienced you are. You will have to check inferior rectus, you will have to check lateral rectus, and then make sure that it is inferior oblique, how thick it is and all. If it is 1 plus, 2 plus, 3 plus, 4 plus, like that, they classify. If it is 1 plus, I do myotomy. Pradeep Sharma may not accept. Myotomy, just put a Z myotomy on the inferior oblique itself. Just lengthen a little bit. That will take care of just 1 plus overactions. 2 plus overaction, 3 plus overactions, I do only myectomy. I don't do the recessions. And 4 plus overaction, there's a thing called, Marshall Parks taught me that denervation and extirpation of the inferior oblique. One Bombay girl repeatedly, 2 times I operated. Again, the inferior oblique muscle has become like a biceps. So what I did was I just pulled down the muscle under the border of the inferior rectus. I found both the nerve and the vessel. I cauterized the whole thing and buried under the tenons. After that, the inferior oblique stopped overacting. So these are the 4 techniques we do for the inferior oblique. Rest of the muscles, I am not going through each and every muscle. It's quite difficult in this period. And after doing the surgery, stay till the anesthesia part is recovered. Because many times, like a lot, I think we walk out as surgeons. Then I think any problem comes. Once one surgeon went, retinal surgeon, he went out of the hospital and the patient had what they call as some rare hypothermia, something like that. He developed that malignant hypothermia. So he had to be called from home. Then we had to admit him in Apollo hospital and then he recovered. But anything is possible. So you stay. The surgeon has to stay till the child recovers. Very, very, very important. And though the mortality rate is 1 in 10,000, we lost about, my score itself is around 25,000. So I lost only 1 case in 2000. And that was anesthetic, this thing. Immediately within 3 minutes, the child died. So that was a very big trauma, and still we are facing in the legally also. So you'll have to be very, very careful. Good anesthesia team. I think don't operate in chota-mota centers, small nursing homes like that. And very, very dangerous. All of you group together. If you are in a private practice, group together and form a good anesthesia theater with equipments, so that you don't land up with any problem, because now you are seeing that more and more the cases of medical negligence, though we don't neglect, they are putting it as medical negligence. And taking the scleral bite, 1/3 of the scleral bite I keep seeing the needle of the 6O vicryl. So don't go beyond that, because I think a couple of my fellows have gone through and through. And it was a beautiful sight to watch on the indirect. I saw that. And it was just like a fountain, the blood was coming, because he has punctured the retinal vessel. And simple, I called the retinal surgeon. So you must have a backup of retinal surgeon. That's very important, however big you are. Luckily, it does not happen to me, because I take a very superficial bite. But the fellow whom I was supervising, I think he went a little deeper. And it's called as cobra's eyes, because when you go the needle and then come out to the retina, like a cobra eyes, 2 eyes will be seen, especially like a bridal suture. When you take bridal suture those days, you will find like a cobra eyes. So this person, it was bleeding like hell, and he cryoed it actually, because the blood was filling up very fast. Wherever the iatrogenic break was created, he did a cryo. So that's a serious complication. So never take a deeper bite. Even if it slips and goes away, other side it will pull. Fortunately, we have also not lost the muscle. That is again another serious complication. And while doing the scleral bite, this iatrogenic retinal break. Infants do we check the muscles. And I normally, my calculation is 1 millimeter of medial rectus recession or resection, 5 to 6 prisms. I don't think Pradeep will accept, but each fellow, one wouldn't say something. In my experience of these years, 1 millimeter of medial rectus recession or resection, 5 to 6 prisms. 1 millimeter of lateral rectus recession or resection, 3 to 4 prisms. This is how I calculate. And so far it has worked. 85 to 90% you get ortho the next day. Then you are the king. If it goes outside or inside, there also I think if it goes for consecutive ESO or consecutive EXO, what I do is I keep some frames, ready-made frames. Ready-made frames with prisms, 3 prisms, 4 prisms like that. Suppose I think over-corrected intermittent squint next day, more than the child, the mother will be jump. She will say that he is seeing double, diplopia. So for this, I put that prism, 4 prisms base out like that, because consecutive is so. And then she will be all right. Otherwise, I think I always believe in only undercorrection for intermittent exotropias. I don't do overcorrection. So this problem is not there for 10 years now. Adults, be careful with the conjunctiva. It will tear off and cause buttonholes and all. And retinal surgeon backup, I told you. I tend to do somehow a lot of tenotomies. I shared last week, I don't know whether Pradeep had seen. Last week I had a case, 4 muscle surgery. All lateral rectus was recessed, or around 6 millimeters only they have recessed. And medial rectus was resected around 5. Still exo deviation of more than 70, 80 prisms. And so I shared the photographs. What I did was I did bilateral tenotomies, free tenotomies, but attached an anchor suture. Because in case postoperatively if the eye goes inside, I thought because the anchor suture is there, we can pull the anchor suture. I leave quite a bit of, put like a tie knot, what we use for adjustable suture, and leave it in the inside the eye itself, just over the muscle. And it will be floating on the conjunctiva. So you can go and pull it in case if it happens. But so far, so many tenotomies I have done, it has not happened. This case I did bilateral inferior rectus, lateral rectus tenotomies with that anchor suture, and both inferior obliques were thick. That also I cut and advanced the medial rectus. And 70-80 residual exo became ortho. So sometimes you will have to be over enthusiastic and keep on doing it. And I don't put any bandage. But actually, if it is a general anesthesia case, no bandage. Any muscles you do, 3 muscles, 4 muscles, I don't put any bandage. But if it is a local anesthesia, I always put bandage. Because after some time, it will open and you will develop exposure keratitis. And see that your hospital has emergency facility. Emergency, this thing, because you cannot be troubled again and again after surgery. So after going home, the parents will have little anxiety. Most of our patients are 75% are outstation, 30 scare like that. They will tell that some problem means they go and report to the emergency. Only if the emergency doctor suspects something, blood oozing out or something like that, they will call the surgeon. Otherwise, he handles them. So a good emergency facility should be there in whatever setup you have. There are 24 hours service should be there, or give a reference to CFS and send it to Pradeep Sharma's place if we are in Delhi. And I always use, when I next day open the eye, I use post-operative, first thing I do was to clean the lids and then apply Propercaine, that topical anesthetic. Then only the child will open. Otherwise, one Bombay child actually stayed throughout till next day. And next day they came, actually child was closing the eyes. And I know that this topical anesthetic causes little this thing. I told, if you are going to, he's doing it purposely, some intentional. So I put drops again. And then that fellow got frightened. He opened the eyes. Then they went to Bombay. So these things you will come across day to day. And adjustable suture, I have reduced quite a bit. Single adjustable suture on the table I have done. But adjustable suture, first this thing after Jampolsky's training, I came and did, and it was thorough suicidal in the sense, a patient in the OPD I did, he developed OCR and vagoreflex, and he almost was sinking. And Dr. Badranath's rule is that every consultation room should have adrenaline and one anesthesia also, that oxygen cylinder also used to be there. So we called immediately the physician in charge, and he took over and it became all right. So sometimes you touch, because once you put local anesthesia, they don't develop this OCR. So this one, I just touched the conjunctiva and he collapsed. Luckily, he revived. So better to have one physician also in the thing. So altogether, institution is always better. And the residual and consecutive, these appear, and then you'll have to explain to the parents. And as we have told before itself, second stage may be possible. Sometimes we adjust with prisms. Sometimes we give little Botox, or I have a lot of frenal prisms, right from 40, 50 also I have. So I put the frenal prisms and send them off to shut their mouth, not complaining diplopia. Then later we may have to think. And I also give them my email ID, and they'll send a photograph every week. Actually, the next day the patient leaves the station because 75% are outstation. Then any problem, they will send an email. So morning, every day morning, 20 to 30 emails I'll have to see before going to the OPD. 20 to 30 emails, and immediately I'll reply. And I don't give the phone number and all, otherwise my wife will divorce. And clear instructions for follow-up, what all to be done, the cleaning, when to take the head bath, all these things. I think Pradeep will have a certain formula. I will have certain formula. You tell whatever formula you have been doing. See that no infection takes place. . coming to lazy eye treatment, I think of late, what I'm doing is in India, what I feel is, I've told Pradeep Sharma a number of times in the conferences, this part-time business, I don't believe. Either it is full-time, what Prem Prakash taught us. You will say for 6 years, child 6:1 like that. I am still following the same thing. And because in India now with both the husband and wife working, the number of hours what the child puts, if you say full-time, they do part-time. If you say part-time, no time. So, and withdrawing of the part-time to this thing partial, just putting on 3M tape like that. That and all I'm doing, but I'm still giving synaptophore exercises. And occlusion therapy still is the sheet anchor. And a lot of children now, I don't do any patching at all, even up to 3 years. Straight away, only penalization. Penalization works very well in my hands. Weekly once atropine at night and ask them to occlude the nose so that the atropine doesn't enter the nose and throat and cause pyrexia. So they are given crocin also in case if it happens. So don't believe in part-time patching at all. Re-surgeries wait for at least a couple of months. Sometimes the squints behave in a very naughty way. Sometimes I think what you see as 20 prisms, it will disappear. What you see as orthophoric, it will appear. So, let me just conclude that today is keratoconus day. Next slide, Ma, anything is there? These are all the conventional. This and all I am not putting now because skin peeling is there. Then accommodative squint. This and all has been taken care by my previous speakers. One of the very few. Actually, 20,000 I have done and I have not taken one picture also pre and post-op. This is unfortunate. Only my associates have taken. Adjustable sutures are not doing. This one I'll just tell a few words. First, I got trained in Children's Hospital. Then I went to San Francisco with Jampolsky and Alan Scott. So he discovered botulinum toxin working way back in 1970s itself. 83, when I went, he told me to give this thing, anesthetic, this thing into the ear of the rabbit. And then he was giving, that was the anesthesia. Then he was giving the botulinum toxin, what he prepared. He didn't tell the secret how he prepared. And then he gave it to Berkeley Bioengineering Company. And then from there to Alargan, and he made a lot of money to buy a plane and all. So Alan Scott's experience was good. Next. So this I have shown already. I am not doing this now. I open the conjunctiva and do it. Those days we used to have a tungsten needle and with the EMG machine. Once you prick, it will make a noise. And this was a sort of adult patient, not cooperative. I had to use little anesthesia, just gas anesthesia. Next, this girl, same girl had like this. The patient who came last week, she had all 4 muscles done at Government Ophthalmic Hospital, Chennai. And she had this much of exo. So after giving Botox, she was like this and she got married. After that, she didn't come. I told her, this will be a sort of honeymoon squint. Again, it will come back. And she never came back. But now I am doing this, what I showed you, lateral rectus tenotomies. So you can find the scar everywhere. Right, next. This I will leave it. I think future modalities, this fellow, Alan Scott is trying some other thing, lengthening the muscle and all. Okay, I think I am done.
Thank you so much, sir. Really master tips from original master for the subject. Thank you so much for all those pearls of wisdom all over that you have acquired all over your career. I'm very sure our postgraduates, for their practical knowledge, it will be so helpful for them. Pradeep sir, remarks from you.
Pleasure getting the tips from Dr. Surendran from his heart. So his vast experience, and he has given so much importance to refraction that he has not stopped. He's still not stopped doing refraction himself. That gives the highlighting the importance of refraction in children, particularly, and also stereopsis. I mean, both these points he has very importantly highlighted. Of course, the other points he has given about the group practice for surgery, for the and the emergency support and the physician support, and the experience of the adjustable surgeries and the Botox. So he has had a vast experience and very practical tips. Really, it will be a great treasure for all to keep in mind.
Yes, so I think most of the questions were covered by the previous speakers also. One question is, in which subset of cases after a meticulous pre-operative assessment can we expect a post-operative surprise? It's like a...
In spite of doing so many, I think it will be a pleasant surprise. Sometimes you may think that it won't be orthophoric, but it will be orthophoric. That calculation is done by God, not by us. 1 millimeter, what I told you is just intuition. It is called as intuition strabismus. You do something and then like magic, it will work or it may not work. So why for Bombay girl, poor girl, 5 times I had to operate. So I really don't know. My problem is only that shakes from women and all. They expect 100% result. Otherwise, they say they will get out. They will go to Pradeep Sharma probably. I don't know. Actually, they go to England. Most of them England because rich sheikhs. Yeah. The Chennai is closer, 4.5 hours. They come. Many of them land up, and the children also will come. Adults will come. One fellow told at the 70th year he wanted to have a squint correction because he's getting married 3rd time, I believe. So at 70th year, he wanted the squint to be corrected. Anyway, all we have faced.
I think so. We can wrap up the evening because it was such an insightful time to listen to sir's experience and make note of it for our career also. Thank you so much.
Thank all of you. I must thank all of you for listening. And my academics is very poor now. Pradeep will know that I am not attending many of the conferences. So anyway, today's lecture, I am enlightened. So maybe I think I should,
it's really a
pleasure. Have like Dinesh Karthik, I should come back, I think. But now he's going back. But come back is always a possibility.
It was an absolute honor, sir, to have you here. Thank you so much for your time this evening, sir.
Thank you. It has been wonderful.
Thank you, Shefali. Thank you, Rolika, and thank you, Santosh, for making it possible for having the master, Dr. Surendran, with us. Thank you all.
Thank you so much, sir. And Shefali would, yeah.
Yeah, 2 announcements to make. One is for the next class, that is November 11th. That is the last word, Pearls in Strabismus, in pursuits of stereopsis. Also,
none other than Pradeep Sharma, sir.
Yes. And I'll quickly share this because this is for all our postgraduate students. Do not miss this opportunity. iFocus Physical is back. So we'll see you all on from 26th February to March 5th. It is in New Delhi and it is only for 300 delegates. So register soon and I hope you can make it there.
Sure. Give me a feedback afterwards.
Sure, sir.
Feedback. Critical, everything.
Yes, sir. Right, sir. And we'll all be there for you for Pradeep Sharma sir's class on Wednesday.
I think that's the last one on Strabismus. Then probably we move on to another.
Yeah, subject. And then we move on to the quiz.
Mm-hmm. Pradeep, one small request.
Yes.
I think I told you already that today is keratoconus day, I believe. wishing all of you a Keratoconus Day. But why no Squint Day is there? Only thing I saw in the Google, Squint Day means they have written alternate days to Squint is cyclic squint, like that they have written. I Googled Squint Day. They have written Squint Day. If it comes alternatively, it is called a cyclic squint, like that. Incidentally, I operated 4 cyclic squints so far. One I discussed with Pradeep is doing well. Pradeep,
Yeah.
Thanks for your counsel.
Thank you so much, everyone.
Thanks again.
Yeah, for the evening, I think.
Yes, thank you, Pradeep sir, for your time, sir.